Welcome everyone and thank you for joining us today for Osteoporosis Canada's educational webinar. Before we begin, Osteoporosis Canada acknowledges the land that our offices located in Toronto are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. My name is Tracie Napoli, Director of Fund Development and MARCOM at Osteoporosis Canada, and I will be your webinar moderator today. This webinar is being supported by an unrestricted educational grant from AMGEN Canada. This webinar will provide general information. It is not intended as individualized health or advice. So if you have questions, we advise that you please contact your healthcare provider. Now, if you have any questions or comments related to the webinar, you can click the Q&A icon at the bottom of your screen or enter your comments in the chat. There will be a short Q&A session at the end of the webinar, and we will do our best to answer as many questions as we can within the time available. Osteoporosis Canada is the only national organization serving people affected by osteoporosis, working to educate, empower, and support individuals and communities on bone and muscle health and in the risk reduction and treatment of osteoporosis. We look to the best experts to inform our care guidelines for patients and care providers. Our Scientific Advisory Council is made up of experts from across the country in osteoporosis and bone metabolism and is a volunteer membership. Comprised of clinicians, researchers, and educators, the SAC advises Osteoporosis Canada's board and staff on scientific and medical issues. Osteoporosis Canada provides medically accurate information to patients, healthcare providers, and the public. Services include programs and support groups, educational webinars like this one, podcasts, digital tools, and resources. You can find these and more at osteoporosis.ca. It's now my pleasure to introduce our presenters for today's webinar, Learning About Bone Building Medication. Dr. Alan Lowe is a clinical professor in the Faculty of Pharmaceutical Sciences at the University of British Columbia, care director at MedInfuse Health, and primary care pharmacist, pharmacy lead at BioPro Biologics Pharmacy. Dr. Lowe is a member of the Osteoporosis Canada Scientific Advisory Council, board advisor with the GI Society, and a member of the medical board of healthchoicesfirst.com, a patient video education resource. He also has an experience in a wide variety of health and administrative settings, including direct patient care in the hospital and clinics, clinical and practice-based research, consultant in healthcare, and clinical projects, as well as health advocacy. We also will be hearing from Barbara Grace, who will be sharing her lived experience. Barb has worked for many years as an office manager of a financial service business and has been retired since 2023. At 64, she remains very active in a variety of athletic activities, and she enjoys spending time with her partner and family at the cabin. Extensive travel abroad is on the horizon once her partner retires. In 2023, Barb was diagnosed with osteoporosis after having suffered multiple vertebral fractures, and Barb is here to share her story. Thank you to both of you, and I will hand it over to Dr. Lowe.
Thank you, Tracie. I'm just going to bring up my slides and then we can get started. Thank you for that introduction. I'm happy to be here. And I'd like to acknowledge that I'm speaking to you from Vancouver, which is the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. I'm just going to start with maybe a bit of a quick introduction with regards to osteoporosis, just to get us on track and slowly ease into this a little bit. But just wanted to let everybody know that the statistics in Canada is that the average life expectancy is 81.7 years, and that's actually increasing, and it's actually a good thing. And we're one of the nations around the world that are doing quite well. But what happens with living longer is that there is a higher chance of fractures as you age. So we do know that fractures are strongly related to fractures. And we see that bone mass peaks kind of at 25 to 30 years old. And the best way to keep the bones strong and keep the bone mass is to ensure that there's enough calcium and vitamin D throughout our life cycle. So from beginning all the way to the elderly years to try to maintain that amount. And I've kind of written the amounts that are recommended. Exercise is, of course, also important. So both balance and functioning training. And an example is doing Tai Chi twice a week. That helps to stimulate all muscle groups and helps to reduce the risk of falls. There's also progressive resistance training. So that's just like weight training, adding weight until you can reach a higher weight tolerance and slowly build up, but don't overdo it. And then also physical activity. That moderate to vigorous physical activity, maybe 3 times a week, adding up to 150 minutes. I just want to remind you about this peak bone mass. So this graph that you're looking at is as you age, from birth until, I guess, up to over 100, you'll see that your bone mass grows as we get into our adolescent years and peaks between that 20 to 35 age. And so that's going to be the most bone that you'll actually build. And actually, over time, what happens is you start to lose bone. And this is natural. Our body just resorbs or breaks down bone faster than it's building it after age 35. And then for women, there is this area around the perimenopausal time. So just around before and after menopause and during menopause, there's this really quick fall of bone mass. And that's a good time to make sure that you're having as much protection or support for the bones as possible. That's your calcium, vitamin D. And if you're already low bone mass or at risk for fractures, to make sure that an osteoporosis therapy is started to prevent and slow down that quick loss. A little bit slower for men, and there isn't such a sudden drop off. There might be a little one at around 70 to 80, but it's not as significant as during the postmenopausal years around that menopausal time for women. Just a reminder, and this kind of speaks to some of the medications that we're going to be talking about, is that we have both bone resorption and bone formation occurring on a regular basis. So this happens all the time. It's not just for a short period. It goes on throughout our life. And when we are growing more bone, of course, the formation is more frequent and happens more rapidly than the bone resorption. And for a period of time when bone mass is pretty stable, they're kind of equal. But then as we age, the bone resorption seems to go faster. And it's these osteoclasts. These are the cells that actually resorb or break down bone. And the osteoblasts come in and fill in those crevices and rebuild it. So it's a good thing that we have this dynamic process that bone is essentially being renewed. But as we age, the osteoclasts get more active, so there's more bone resorption, and the bone formation by the osteoblasts seems to slow down, and that's what puts us at risk for fractures. So this is essentially what's happening in the body, and we always are looking to ways to slow down that resorption and increase the formation if that's possible. But naturally, it does go to this bone resorption greater than formation as we age. So if we look at the risk of fractures, we can begin with a 10-year fracture risk that's less than 15%, and we'll consider that low. And at this point, guidelines out there in the world do not recommend that there's specific prescription therapy needed. But still, that calcium and vitamin D and exercise is a standard and should always be there. As we age and as there are other risk factors and conditions come along, or our bodies are genetically programmed to lose bone too fast, or if you haven't reached a really high bone mass, what happens is your T-score, the bone mass, drops below minus 2.5. And at that time, there is increased risk of fracture. And that's also where often the diagnosis or definition of osteoporosis come in, that T-score less than minus 2.5 when measured by a DEXA. The other way is to do a FRAX risk assessment or a CAROC risk assessment. The FRAX is one of the preferred ones. And if you go to this website to look up FRAX, you can actually calculate your risk score, and it's a 10-year risk fracture, and between 15 and 20% is considered high risk, and that's when prescription therapy is considered. And as we get into even thinner bones or higher risk, this is where we fall into a 10-year fracture risk of greater than 20%. And that, coupled with low bone density or elderly age, really puts people at risk for fractures, as well as if they've had a fracture before. There's many studies coming out now, and more supporting this, is that if you've had one fracture, the risk of the next fracture is very high. And it is a very, I guess, strong implication and a strong recommendation to start therapy. So it's not just the exercise and calcium and vitamin D will cut it. That person definitely needs something to prevent fractures, because the risk of fracture is so high and essentially imminent at that point. So there are a number of treatment options out there. And when I talk about treatment options, these are the prescription drugs. And this is in addition to calcium and vitamin D. So all of the studies done in the last several decades all included calcium and vitamin D in the placebo arm. So that's just basic requirements. All of our agents or treatments are on top of that. So we have our anti-resorptive agents. These are the ones that prevent the breakdown of bone. They include the oral bisphosphonates. So there's a couple out there that are oral. That's alendronate, risedronate. We also have IV versions. It's a zoledronic acid, sometimes referred to as zoledronate, and it's given by intravenous once a year. The rank ligand inhibitors, like denosumab, the other name for it is Prolia, and it's a subcutaneous injection given every 6 months. And then there's hormonal therapies that are possible as well. So these are the estrogen, progesterone kind of hormone replacement type treatments. And then also these selective estrogen receptor modifiers, or SERMs. And one of them out there is called raloxifene, which is given once daily and also an oral agent. There are a couple of anabolic agents out there, and right now there's not very many to choose from. So there's a parathyroid analog, and I'm going to talk more about these, and that's teriparatide. It's 20 micrograms given subcutaneously once a day, and it can be used up to 24 months. And then there's also sclerostin inhibitors. This is romosozumab. And actually, I forgot to mention that teriparatide, the name that it may be more commonly known as, is Forteo. That's the originator that made that particular drug. And for the sclerostin inhibitor, romosozumab, that one is Evenity. And that's given as 2 subcutaneous injections. It adds up to a total of 210 milligrams. And that's injected subcutaneously once a month. And that's given for a maximum duration of 1 year. So with very high fracture risk, these are some of the risk factors that easily identify those at very high risk. If there's been several fractures or recent fractures, if there are fractures while on osteoporosis therapies, if there are fractures while on treatment causing harm, as well as other treatments that weaken the bones, such as glucocorticoid or corticosteroid type therapies. If the T-score is very low, if it goes below a minus 3.0, which is a very thin bone or very low bone mass, and also if there's a high risk of falls or a history of injury from falls, it's also very reasonable to consider that as very high risk, meaning that some strong treatments, or this is when we think about those anabolic or bone building drugs. Some of the factors that indicate high risk is a prior fracture. Fragility fracture refers to a fracture that occurs, and it shouldn't have if the bones are normal. So falling from a standing height shouldn't actually break a bone. And if it does fracture, that suggests that it's a fragility fracture and your bones are weaker. A high FRAX score. So when we calculate the FRAX, and you can see the website to access the FRAX calculator on the top there. And if that score is calculated to be essentially more than 15%, it puts us into a high risk category. Over 20% is a very high category. And also if the T-score is less than minus 2.5, also puts people at high risk. You can see that at the very high-risk treatment, it's denosumab, romosozumab, and teriparatide that are the most recommended. And it is only the romosozumab and the teriparatide that are considered anabolic agents. So anabolic meaning that they actually build additional new bone. The other treatments, such as the ones used for high risk, such as oral bisphosphonates or denosumab, they generally slow down the breakdown of bone, but they don't really stimulate the increase or the formation of additional bone. So you can look at these agents as being, I guess, different levels of, I guess, strength in protecting and building the bone mass. Just to mention that all of those treatments do prevent fractures. So it's not that they don't, and they all build some bone mass, and some build more than others. So romosozumab, Evenity, is a biologic medication. It's targeted to block the action of something called sclerostin. And what happens by blocking that is it does lead to new bone formation, and that is more osteoblast activities. So those cells that build bones just act faster, and there's more of them. And it also decreases bone resorption as well. Sometimes this drug is referred to as dual action because it is both increasing the formation and decreasing the resorption, or the breaking down of bone. It's generally reserved for severe osteoporosis or for those at high risk of fracture, as I kind of summarized in the previous slide. And it also has been shown to help increase a bone mineral density among the highest. And that seems to work the best if the person has not been on any other therapy before. So most of the studies have looked at people who have not been treated, and those who have been treated with a previous anti-osteoporosis agent, they don't quite build as much bone mineral density, but there is still an effect in preventing the fracture. So certainly still useful to use. Again, it's administered subcutaneously. It's 2 injections in 2 different locations subcutaneously once a month, and that's done for 12 months. And to maintain or keep that bone mass that's built, it's important to use an anti-resorptive agent after that. So that's when we want that treatment to come in to prevent the breakdown of the bone after we've built it. So it is important to consider when you start this particular medication if you're looking at coverage, because a lot of times, and I'll get into it a little bit more, is that these are relatively expensive agents. And many of the health plans out there kind of have annual deductibles that they can be set annually or by the calendar year. And so if you, let's say, start at 6 months into that deductible year, you may end up paying it and never reach a deductible. And then when it resets, you pay another 6 months. Whereas if you started it at the beginning of that annual reset, there would be coverage kicking in for your treatment of that's being used. Some of the more common adverse effects seen with romosozumab are joint pain, body aches, and that kind of thing, reported about 13%, headaches reported about 7%. Now, keep in mind that in these studies, even placebo has joint pain and aches reported up to as high as 10%, 11%, and headaches as high as 6%. So even though people are not receiving medications, there's still reports of adverse effects, and they still get reported. Now, something that was a little bit worrisome, and this causes a warning to be issued with this drug, is that these studies have reported cardiovascular events that were slightly higher than placebo. So it's in the neighborhood of a 0.3% versus 0.2. But because these side effects are so significant, these are heart attacks, strokes, and death from cardiovascular events. They occurred rarely, but because there's this numerical difference, there's a recommendation right now in the monograph to say not to use these medications with those who have had any cardiovascular disease or have had any past history of strokes or heart attacks and things like that. So this medication is generally considered safe, and the side effects are very comparable with bisphosphonates, and in some cases might be even considered safer from the point of view of less atypical femoral fractures, and is also believed to have less impact in causing osteonecrosis of the jaw. As I was mentioning, romosozumab is a higher cost drug. It works out to about $800 a month. There is public coverage in almost all provinces. I think Alberta is still working on it where coverage is not there. But there's also private coverage as well. So these are your private plans. Regardless of whether it's public or private coverage, there's going to be something called prior authorization or prior approval needed. And that's because to help, I guess, protect healthcare dollars is to not use these medications too frivolously, meaning that there are criteria that make sense for people to use this drug. Sometimes physicians and specialists do feel that the criteria are too stringent. The studies have looked at mostly people who have not been on other therapies before, but there are some studies looking at the use of romosozumab, even though you've been on treatment. But unfortunately for coverage, it's only used in what they call naive patients. That is, patients who have never received the use of a osteoporosis prescription therapy in the past. And they also have to be at high risk of fracture. So being an expensive agent and very powerful, it's generally not used in those with mild risk or low risk of fracture. And that definition of high risk is greater than 20% in the next 10 years, as calculated by FRAX or one of the other risk calculators. If there's no public coverage possible, the manufacturer has created a program. It's called the Patient Support Program with the name of ProVital. And with advocacy and requesting coverage, it's possible to receive up to 40 or 50% coverage. And there needs to be application to this program for it. And this is in the case where other coverages may not be available or where public coverage isn't available. There's many cases where even if there's private plan coverage, that there might be coverage through this patient support program available. Coverage is only up to 12 months because the studies have all only looked at the use of this drug for 12 months. And it's not known whether going over 12 months is going to be useful or not. And so it's not approved for that. This medication does have to be stored in the refrigerator. It is a biologic, should be protected from light. And it includes an injection once a month of 2 injections. And each of those injections are approximately 1 milliliter that's injected under the skin subcutaneously. Just want to switch a little bit and talk about teriparatide. So this is essentially a parathyroid hormone. It's also an anabolic, so it does help to build new bone, but it doesn't slow down the resorption of the bone. In fact, if we were to measure resorption, it actually increases a little bit because both the osteoblasts and osteoclasts, those 2 cells building and breaking down bone, are kind of linked and coupled. If we build faster, the cells that actually break it down also work a little bit faster as well. Good thing is that the building is still far outweighing the breaking down of the bone. So teriparatide does build new bone. And this particular drug's a little bit more complex in that being a biologic, it has a biosimilar. So that is a medication that is highly similar to it, but not considered to be chemically 100% identical. And then because this molecule is small enough that it's possible to create a 100% identical creation, there are generics out there as well. What's the difference between these two? Well, in Canada, biosimilars are not interchangeable. That is, if the prescription says it was for Osnuvo, which is the brand name for the biosimilar teriparatide, that's what the pharmacy will fill, unless there's a good reason to switch it, which they have to exercise different authorities to get it changed. It needs to be filled with Osnuvo. If it's prescribed as Forteo, it can be actually interchanged and switched over to the generic, as you might have seen with other generic medications, where you can use a generic even though the brand name is prescribed. And it's up to the patient and the doctor to say if they didn't want it substituted to a generic, can express that to the pharmacist. Coverage, however, is not always the same, and different plans may cover one or the other, and a lot of times they are focusing on the generic because they are lower cost, as well as the biosimilar, which tends to be at a lower cost as well. Some of these programs with the generic companies and with the biosimilar also have a patient support program and can provide a little bit of financial assistance, but not as high as the percentages we've seen with the Romosozumab or the Evenity. So with teriparatide, it's also a biologic medication, but it is a synthetic analog of parathyroid hormone, allowing it to be made both as a biosimilar or as a generic. And how this drug works is it essentially activates osteoblasts to increase bone formation. But as I mentioned, it doesn't block the resorption. It's also, of course, with the criteria that are involved in getting coverage. It's reserved for those with high risk of fracture or severe osteoporosis. And it is an anabolic option, and it's a better anabolic option for those with a history of cardiovascular disease when we're looking at comparing it with romosozumab. And it's just because of that association of romosozumab having some reports of cardiovascular issues that were seen in the studies at a slightly higher number than what was seen in the placebo. Some of the adverse effects associated with teriparatide include joint pain, leg cramps, weakness, aches in the body, and it's reported at about 9%. And then nausea and gastrointestinal symptoms somewhere between 2 and 9%. Depends on the person, of course. It's not used in people with a history of bone-related cancers, young adults or children. And this is because it's affecting just the bone resorption part and is also a parathyroid hormone, so not to interfere with the development of the body and that kind of thing. And because of animal studies that were done, this is where the warning of the bone-related cancers and not using it there comes in, because it did show some signals when used at a very high dose in rats in studies. So some of the safety testing that is done in animals. So it is also generally considered safe, and its effects are comparable with bisphosphonates from side effect profile. In some cases, it could be better or worse depending on how you're looking at it, because there are injection site-related reactions because you're injecting this on a daily basis. And it's also believed to have less impact on causing atypical femoral fractures or that osteonecrosis of the jaw. Its price tag is about $620 per month. There is public coverage in only a couple of provinces only, and that's in Ontario and Quebec. And then private insurance does cover it, and they all require a prior authorization or approval. So generally, those criteria include those that are over 65. They have to have a high risk of fracture and also are not able to use other treatments. So this seems to be the only one, and that's when coverage might be provided. The patient programs, as I said, might provide some financial assistance, but you do have to request it and have to apply for it through enrolling in their program. And with this drug, it's still looked at as something that limits to 24 months of use. So again, this comes from studies and from what we anticipate and expect the drug, how it works, that the limit is up to 24 months. It also has to be stored in the refrigerator, protected from light, and subcutaneously administered on a daily basis. And one thing to remember is that it comes in this injectable pen that gets reused for 28 days, so not to discard it after one dose. And sometimes caregivers and nurses that aren't familiar with this might think that it's discarded, but it actually continues to be used for 28 days. So the order of the drug use matters, and that's why with Romosozumab that there's this criteria of a patient has to be naive on medications, that is, they haven't been on anything before. The graphs here show the use of Teriparatide, then at the switch point switching to denosumab. That's the red line. Then there's the green line, which is denosumab switching to Teriparatide. And then the last one is combination usage of an anabolic together with denosumab all the way through. And you can see that the way to build the fastest and the most bone is either through the combination used at the beginning together, or going from teriparatide and then going on to an anti-resorptive to keep the bone that's built. We see that when we switch the order and we use denosumab first, that the teriparatide doesn't have as much of the ability to grow the bone. And that's because it's been, I guess, blocked by the anti-resorptive, which is slowing down the breakdown of bone. And because of that linking and coupling of these two cells together, it's diminishing its impact. The right-hand graph is showing the impacts on the total bone measurement in the hip and looking at the total hip. And we see similar kinds of effects, except that it seems to even have a stronger effect if we use it out of order, with that green line with denosumab going to teriparatide, not being able to build as much bone as we could do with the other cases. So this is why that the criteria require with romosozumab that if you've been treated with anything else before, that many of the plans won't cover the cost of the romosozumab, thinking that you're not getting as much out of it and therefore reluctant to, I guess, see the value or be able to pay for it. Before I just kind of finish off here, I just want to mention that it's really important to prevent that next fracture. And identifying that fracture risk is extremely important. If there's a previous fracture, make sure that you see your doctor to talk about preventing that next fracture. Rehabilitate that fracture, improve balance, work on the strength, build the bone density with exercise, and if a medication's needed. And we focus this on a lot because we find that the data tells us that despite after a heart attack, 90% of people get put on drugs that will prevent the next heart attack. We're not seeing that with fractures. Only 10 to 20% of people who have had a fracture get any treatment or proper follow-up with respect to treating and preventing that next fracture. And we see the same with subsequent fractures, that once you fracture, there's a high chance of fracturing again in the first year and in the first 2 years. So this is the data from the first 2 years that we see that 61% of the people who have had a hip fracture will fracture again, 54% with forearm fractures and a wrist fracture. And we can see that 1 year is also very high. It starts to decline as years go on, but in those first 2 years, there's a really high chance of fracturing again. So it just emphasizes the importance to look at that. So there's certainly many options of osteoporosis treatments out there. It is a really tough consideration sometimes when you think about this is one of the few conditions where there's oral medications, subcutaneous injections, or intravenous. They can range from once a day, once a week, once a month, every 6 months, or once a year. There are anti-resorptives, and then there are anabolic agents. The cost can range from $150 a year to $9,500 a year. So you can see that the huge options list, and everyone is an individual. So, of course, the recommendation is to speak with your physician and healthcare practitioner about the benefits and the risks of the treatments, as well as the costs and coverage, and certainly look into financial assistance as available for some of those higher cost drugs. So with that, what I'd like to do is pass it back to uh, Barb to kind of share her story, to give you an idea of what she's kind of gone through. And so, Barb, I'll let you take over and tell a little bit about your journey.
Okay, thank you. Hello, everyone. My journey started in August of 2023. My partner and I were in Montreal on vacation, and we decided to rent bikes to tour the city. So we ended up in Old Montreal, and we landed on cobblestones, and I noticed that I kind of felt like my body was almost rattling. It felt really terrible. So we got off of those quickly and finished our vacation and went home. And I noticed that there was a pain in my thoracic spine, my upper back, kind of close to my shoulder blade. And it was a very deep pain. It did not feel muscular. So I went to a clinic and had an x-ray, and they said, they didn't see anything, which was great. However, the pain persisted. So I did go to a sports doctor, and I was sent for an MRI, and then I was sent for a CT scan because they were looking for cancer. So in October, third week, I was told at my appointment that I didn't have cancer, which was absolutely amazing. I felt like I had a new lease on life. This was great. And as I was leaving the doctor's office, I did say, what's next? I still have this pain in my back. And I was told then that I would be going for a DEXA scan at some point in a few months. There was no panic. I didn't question that. I should have. But I was told to carry on, go to physio and just carry on with my life. So I did. Things were good. I assumed quite healthy. So it only took about a week and a half for things to kind of fall apart for me. My back, I had so much pain I could barely move. I realize now I'd had a couple of compression fractures in my thoracic spine, but at the time I did not know what it was. I actually just thought my back was falling apart. It was a very, very bad time. I actually couldn't even hold a mug in my hand because it was too heavy for me. So I did see yet another doctor about 2 weeks later just to find out what was happening to me. And I was told that I had osteoporosis and that I should start physio. So I went home and I started researching osteoporosis. And I landed on the Osteoporosis Canada website. And that's where I learned so much. I watched everything. I learned how to, what was possibly happening to me with the fractures, how to move. I learned different medications that would be offered, possibly, just what to eat, just what it was. It was a very helpful website. And I also checked out other sites as well. At the end of December, I did see my endocrinologist, new appointment. I've never met him before. And his suggestion or recommendation to me was that I go on Evenity based on my fragility score and my fractures. So based on my research, that would have been my recommendation as well. Everything I'd read about Evenity seemed to be the drug for me if I needed to go on some type of medication. So we discussed it, and I knew there was, some side effects, but decided that that was the way to go. The drug wasn't paid for by the province or anything. However, as mentioned, the manufacturer did provide a discount, and that was all taken care of by the doctor's office. So it was, when I picked it up from the pharmacy, it was already covered off. So I started Evenity January 2024 for 12 months. In February 2025, I had a DEXA scan and I got my results in March. And the doctor told me he had never seen such good results. I was no longer in the osteoporosis range, but had moved into the osteopenia range. So amazing news. I was very excited about that. And today I am very active. I exercise a lot. I take care of myself. I eat well. My hope with this story is that people realize that there are others going through the same thing that you may have gone through or are going through, and there is recovery from this, and you actually do heal, which at the time I didn't know that I was actually going to heal. And that, I live with this daily, but it's okay, and there is life with osteoporosis. So thank you.
Thanks, Barb, for sharing your journey and what you kind of went through. It's great that you're able to get in and be seen. I know some folks also have difficulty having access to
Yeah.
physicians and things like that, or folks like that. I'm wondering if you can describe a little bit more about that discussion you had on how to arrive at which treatment option. So lots of treatment options for osteoporosis and preventing that next fracture.
True. There was, honestly, wasn't a lot of discussion. The recommendation was Evenity. The doctor did say to me that he felt that, given my fractures, and that I was considered fragile, and that this would be the best drug based on its, building bone. And because I knew so much about it, we didn't discuss other options. He did say that the results from other patients were very good, and so that's where we landed, very in a way rather quickly, because I had done my homework and I knew what I was looking for.
Well, it's great that if you're walking into the office knowing what your preferences are, since there are many options that are out there. How did you feel about doing the injections? Like, was that something you're comfortable with? And I know some people are
Um,
not crazy about needles.
Yeah, I wasn't crazy about it. You get used to it, and honestly, it was kind of worth it, I suppose. The first time we did them, my daughter-in-law is a nurse, so she was doing them for me. Thankfully, that was great. But we did them in the arm first. Not a good idea. Not enough flesh there, I guess. So the belly was much better, and it was a little uncomfortable for 2 days afterwards, and then it was nothing.
Yes, after a bit of getting used to it, I guess it does get pretty easy.
Yeah, and you know what? It's 12 months. So, if someone said you're going to do this for the rest of your life, I'd think
Yeah.
about it a little bit more, I suppose.
Did you have any worries about starting that medication since it's still relatively new and it is an injectable? I know some people have some concerns. What were your apprehensions before starting?
Well, certainly the side effects. And also, is it going to be effective? It isn't for everyone. It doesn't work on every single person, and I'm not sure why. So there's that. You go to all of that and find that it didn't work. And side effects were a real, obviously a real concern. I was lucky to not have too many. And certain things that I did feel, even joint pain, I would say to you, I thought at one point, maybe around month 6, that I had terrible joint pain, but in fact, it's gone. And so I don't know if it was the drug or just a time in my life that I just had, maybe my knees were extra sore. But that was one of the big considerations: is it going to work, and how bad could the side effects be?
Right. Well, it sounds like it did go pretty well with you. Before starting it, were there any tests that were done? I know that there are some questions that were in the chat there about looking into heart disease and that kind of thing. Sounds like you didn't have any history of that. Did the doctor do
No.
any tests or did anything?
Full blood tests of all kinds, of course. And I had no history of anything with my heart or anything like that. So that wasn't a concern.
Right. And I think that's one of the biggest concerns about this particular drug, just because when you do reading about it, there is this
Yes,
caution around cardiovascular disease. But because it is such a rare occurrence, and it is really just because it was pointed out in clinical trials that's slightly more than placebo, there is, of course, better monitoring and concern about it. But it doesn't seem to be to the level of doing tests on someone who has no symptoms, no reason, and no, fear of cardiovascular disease. But I think with anyone that might have any history, even family history, it's worth
right.
that conversation to assess and check it out with a physician. Each
Definitely.
person is going to be different. And as the risk of cardiovascular disease is higher, then it poses more on the risk profile compared to the benefits. And as with all treatments, we always do a risk-benefit measurement to it. So I was wondering, in your mind, how did that risk-benefit balance go? What did you look at as the big benefit, and what did you look at as the big risk as you were weighing it out?
The big benefit was obviously the bone formation, hopefully helping with the increasing of the bone density. I did everything to, help with that, but I know that the drug obviously was the bigger piece in my results. So that was the fractures were terrible. So for me, if this could help with making me stronger and more stable, that was very important. The side effects were definitely concerning. I've never been on medication, so I wasn't too crazy about having to do that. However, the idea of living, I'm young enough to the idea of living for so long without trying to do the best I could do to get stronger, it just outweighed the side effects. Now, I was also very, I feel lucky that I didn't have anything too terrible happen. So, but that's what, I mean, my partner and I discussed it, and that's just where we landed.
Right. And where are you now with your treatments? Have you finished the 12 months of the Evenity, or are you still continuing?
Oh, yes, no, I finished. I'm in the osteopenia range, and I've started that reclass, the zoledronic
Yeah.
acids. Yes, so I had that in February.
Okay. So as I mentioned, kind of in the preamble there, that some anti-resorptive should be used after you build that bone. So now
Right.
that you're in the osteopenic range, it's perfect that you are on an anti-resorptive. And zoledronic acid, it's called reclassed in the States. In Canada, its brand name is Aclasta. And there are now generics of zoledronic acid now that are being used, and it is a once a year. And so that keeps it so that you don't have to be taking something all the time, which is also very
Yes.
good. And maybe you can describe how did that, it goes back in February. Any issues, problems, or side effects as you received that one?
Yeah, they do say that you feel kind of fluish for the first while, and actually, I really did. 5 days feeling pretty bad. Um, but I got over that, thankfully. But I did feel fluish for sure. That was a big part of it. And then it went away.
Okay, that's great. And that's, you probably had a little bit more side effects than the average person might get, but that generally is about how people feel. And some ways to minimize that. So on your next infusion, if you haven't had this recommendation to you before, is to hydrate really well. So drinking a lot the night before and even the day of, having a couple of glasses before going into the infusion seems to reduce the side effects from the zoledronic acid.
Yeah, I did actually probably drank too much.
Oh, you drank too much.
Yeah, maybe
I don't know if you
that
can
was my
drink too
problem.
much, but well, that's good. Well, thank you so much, Barb, for sharing your story with us. I think we do have some time now to kind of go back to questions. So I'd like to maybe pass this back to Tracie if you've got some questions for either of us.
I do, and I just want to thank the both of you. That was just so informative. And Barb, your story is so compelling, and thank you for sharing. And thank you for actually, Alan, asking about what Barb you're on now. That many questions came on. People were wondering, so what is your treatment regime now? So that was really helpful. We do have some questions also around, bone building medications. Should somebody in their 40s and 50s diagnosed with osteoporosis, would that be a suitable option? Or
So
does
in
it
the
matter?
Yeah, so I guess it matters only for teriparatide with respect to using it if bones are still being, I guess, formed and are new and what they call the epiphyses haven't closed. So adolescence, early 20s, it certainly should be avoided. It'd be unusual for somebody in 40 to 50 to have high risk of fracture, but it certainly can occur. And for those that are at high risk and anabolic, whether it be the Romosozumab or the teriparatide, either can be used in those situations, provided there are not other conditions or other issues going on. But it's probably important to look into why are bones fracturing, or why is there a high risk of fracture at such a young age? We know that it occurs commonly in elderly and older folks because our bones thin over time, but they shouldn't become so thin and weak in the 40s and 50s. But certainly after that's looked into, it's still a reasonable treatment option to consider the anabolic agents.
Okay, great. And are there any new medications on the horizon for osteoporosis? Do you know of any?
There are certainly some research going on, and that's an ongoing thing. So there is another sclerostin inhibitor that is being looked at and possibly can be coming to Canada and hitting other parts of the world, and that's Blazosumab. So these are difficult, and when they're new, you kind of have to wrap your mouth around them. But it's another monoclonal antibody biologic that is targeting the same target as Romosozumab does, same as the Evenity. And so that's being developed. There's other protein-targeted agents as well. So something called andanogatib. It is certainly still being studied. It also looks at a different way of protecting the bone and increasing the activity of the bone building to see if that might be a way to do it. There's other treatments that are in very early phase, and these are different growth factors, and they call them active related differentiating factors, which means that it controls what a cell's going to turn into. And so if we can control that, we can make cells turn into osteoblasts maybe more frequently and therefore build new bone. So there's certainly ongoing research, but I think in the short term, what we'll probably be seeing is more biosimilars coming out for denosumab. Romosozumab may be coming off patent in the next several years, not for a little bit of time yet, but a biosimilar may come out there, which may reduce the cost of the Romosozumab. But that's kind of what we have so far.
Okay, great. Barb, there's a question for you, and some people are curious why an endocrinologist was the person that you were referred to. I know everyone's healthcare team looks different for many different reasons. It could have just been what your doctor chose to refer you to. Do you know why?
Yes, after seeing the sports doctor, I did then have an appointment with my GP, and she's not an expert in osteoporosis, of course, and she knew about my fractures and just, what I was living with at that time. So she felt that it was important that I would see a specialist, and so that's why I was put through to the endocrinologist.
Okay, great. Alan, do you have any comments on that?
I'll just make a comment about osteoporosis. It's one of those conditions where it's everybody's responsibility in the medical world, but because of that, it's nobody's responsibility. Something like rheumatoid arthritis, a rheumatologist would be the targeted medical specialist to look at it. But when we say osteoporosis, it's looked at and treated by endocrinologists, by rheumatologists, by geriatric medicine specialists, by OBGYNs, by internists. And even some nephrologists, because with kidney disease, it also leads to osteoporosis. There are just so many different specialists that deal with it that a lot of times it does get missed. And I just want to emphasize the importance of people taking, responsibility for their own health. And if you've had a fracture, make sure somebody looks at that and treats the fracture. It sometimes gets pushed to the bottom of the list because there are fractures that occur that people don't even know. And I'd like to use this one as an illustration to some folks that when you see someone walking around that's hunched over, they call it a dowager's hump. But when you're hunched over and your neck is bent like that, there's been actually 4 or 5 vertebral fractures. So fractures in the spine that have occurred. And you don't even think that it's anything because it didn't hurt. And that's because there are no nerves on bone. So you can have asymptomatic fractures, and actually 2/3 of fractures don't have any pain. Only 1/3 of fractures actually do have pain in the back. And so it's important that you don't miss it and that you bring it to the attention of a physician. And it could be a referral to many different specialists. So don't be surprised, why is it endocrinologist or rheumatologist or geriatric medicine specialist? There's so many different groups that specialize in osteoporosis.
Wonderful, thank you. Um, we have another question. Does using hormone replacement therapy keep the bone gains after completing Evenity treatment?
Yeah, so hormone replacement therapy, and it's the estrogen component of hormone replacement therapy that actually is the anti-resorptive component of it. So we also see like the SERMs, which is raloxifene. It is also an estrogen derivative. They all can reduce that resorption, and that's the goal. After a bone builder, we want to preserve the bone that's built. So any anti-resorptive has been used and shown to be effective, including hormone replacement therapy and estrogen derivatives.
Okay. So this is kind of another sub question on this. Somebody's asked, they're on hormone replacement therapy, they're being taken off to go on Evenity. It's not that you can stay on both. Obviously, they're on there maybe for a different reason and not osteoporosis.
Yeah, so the combination of hormone replacement therapy or hormone therapy with these anabolics, I don't recall any big studies out there on that. There are studies of using combinations, certainly with denosumab and some with alendronate as well. So using them together is not as effective as using the bone builder first and the anti-resorptive after, but it is okay and has been used. You might not be getting as much bang for buck out of that drug anymore, just because we've stopped or slowed down the resorption. And because that building and turning it over, resorbing is all coupled and linked together, by slowing down the resorption, we're not going to have as much bone building when we start that bone building drug. So it's okay to use. It's okay to use together, but each person has to be assessed by the physician for their particular situation. Like I said, the hormone replacement therapy is not the one that's studied most often in combination. It is the bisphosphonate or denosumab that has been studied together.
Okay, great. And I know Barb has shared what her follow-up is after taking Evenity, but is there a specific option that people should look for in follow-up after Evenity, or does it really depend on the individual situation?
The most studied would be using denosumab, and then the next well-studied is using alendronate. But with that in mind, based on how the mechanisms of these anti-resorptive drugs work, we would anticipate that any anti-resorptive would have a similar effect. But if we're going with evidence in the studies, those are the two medications that are most strongly looked at and have predictable outcomes, just because we've got thousands of patients who've been looked at, studied, and have some measurements behind that to show that it has the ability to keep what's been built and prevent the bones from breaking down further.
Okay, great. And we have time for one more question. And you've both touched on it, but there are some questions around exercise, calcium, vitamin D, other nutrients. Can you impart how important it is to continue to include all of those areas in while taking medication for good bone health and dealing with osteoporosis?
Absolutely. And this myth or confusion may come in because the studies looking at calcium and vitamin D alone, we don't do anymore because it's just been determined as that's the basic building block. So I guess I'd like everybody to think about calcium as what makes up our bones. It is a high percentage of calcium in bones. And if you don't have enough calcium in the body, which it needs to do other processes, it's going to steal it from the bones. So it means breaking down the bone, releasing the calcium so your body can use it. So taking calcium, whether it be in diet, which is the preferred route, having 1,200 milligrams of elemental calcium from your foods is ideal, but it's hard to get. It's mostly in dairy products. So if you're not able to consume enough dairy products, and think of a glass of milk having about 250 milligrams of calcium, that's all that's in there. And so you need several glasses or several servings of dairy, which is difficult. And calcium is that basic bone builder. If you don't take enough of it, your body's going to take it from your bone, which is going to weaken the bone. Vitamin D is also important in that it is very hard to find it in our foods. If you actually look in the foods that are not fortified, like we can artificially add it, but if you're looking for it in food, it is hard to find vitamin D. And depending on which part of Canada you live in, particularly now that we're in winter, there's not a lot of sunshine that gets your skin to make vitamin D. So it's also important to take that vitamin D. And if you ask, what does vitamin D do? It helps your body utilize and absorb the calcium that you take. So if you were taking calcium and your body did not have enough vitamin D, a lot of that calcium is just going straight through your body in and out. It's not even getting absorbed properly. So you need sufficient levels of vitamin D in order to use the calcium that you're eating in your diet or taking as a supplement. So both of those are basic and just needed regardless of what kind of prescription therapy you're taking for osteoporosis. In fact, the prescription therapies don't work as well if you're not taking enough calcium and vitamin D, because you think about it, if you don't have the basic building blocks to build bone, how can any of these treatments really help you? And so we really do need that calcium and vitamin D.
Wonderful. Thank you, Alan. So final thoughts. I'm just going to go to Barb. Do you have any final thoughts? How are you doing today? Any thoughts for the future?
I'm doing well. I will live with this, for the rest of my life. And I've learned, I'm hoping that I think about it less as time goes on, because it'll become just natural. And that's my hope. And, I hope that I'm able to keep, building bone and educating people, if there's a way to do that, so that people understand just how important it is to get that bone built up, so that you don't end up with fractures. Fractures really they change your life, for sure.
Absolutely. Alan, do you have any last thoughts as we wrap up?
I do. It's wonderful that there are many hundreds of people that are on this webinar today. And I know that there's lots of questions. I know that we received lots of questions before this webinar. I've tried to build in as much as possible into the presentation, but of course, impossible to cover everything. I want to remind everyone that the Osteoporosis Canada website is a great resource. And many of the questions that I see kind of popping up in the chat and that we saw posted before this webinar are actually answered on the website. So do some reading. And of course, in your particular circumstance, it's best to talk with your physician or healthcare professional to kind of look at your situation specifically. One thing that I see coming up commonly that I just wanted to mention is that there are people wondering how long should they be on a therapy. So for the bone building agents, we have specific times because the studies have a strong suggestion. So for Evenity, it's 12 months, no longer. For Teriparatide, it's a lifetime exposure of 24 months and not any longer. So those are pretty clear. With respect to the anti-resorptives, that's less clear. But what is a strong recommendation is to reassess if you've been on one of those anti-resorptive treatments for 7 years or longer. It is an important time to look at it again to see if it is important to switch to another agent. And it is because of how it's slowing down the resorption that as it goes beyond that 10-year mark, it might be an increased risk of, let's say, the atypical femoral fractures. It's hard to get that kind of data because you can only get it from people who've been on the drug for a very long time, and it's not that many people, and they're no longer in studies. So this is just coming from reporting. But I think it's a general recommendation. If you've been on a treatment, the same one for 7 years, really a good time to look at it again. And with hormone replacement therapy, if it's been 5 years, it's a very good time to look at it again, just because hormone replacement therapy is really over that perimenopausal, menopausal time, and it may not be needed after that 5-year mark when the risk of potentially breast cancer starts to increase with that estrogen component. So duration of therapy is important with the individual therapy, but protecting the bones is generally a lifelong kind of endeavor. So our bones do weaken as we age. Very important to look at ways to prevent it. And exercise, balance exercises and strength exercises are a lifetime ongoing thing. If you can do it, do it. Try to advance and do it safely. But preventing falls and keeping your balance up there is certainly very important. So again, referral to the website, check out the websites and the Canada Health Guide with regards to diet as well to help make sure that you're getting the right diet.
Well, thank you. And, thanks to everyone for all their questions. We do have to wrap up. Again, thank you to Dr. Alan Lowe. Thank you to Barb Grace. Wonderful, wonderful webinar. So many people are actually popping in the chat how much that they enjoyed the webinar. Thank you also to AMGEN Canada for supporting this webinar by an unrestricted educational grant. As Dr. Lowe just said, there are lots of resources. We have the following coming up. We have a cooking demo on November 20th. In January, we're already planning. We have a menopause and bone health webinar. In this instance, we are going to be answering all the questions that are submitted related to the topic. That is how we are structuring the webinar. So Dr. Nesha Yüksel, she will be with us. You can register, and that's the topic on Wednesday, January 26th. Now, if you do live in the greater Sudbury area, next week, we have an English event and then we have a French event on orthopedics and physical therapy supporting good bone health. It will be at the Radisson Hotel Sudbury. Advanced tickets are required, but you can get a ticket and you can hear our keynote speakers. All the information's on the website, osteoporosis.ca/event, or it's on the homepage. And let's see, there we go. Just a quick note, our offices, we have moved. Osteoporosis Canada has a new mailing address. Not to worry if you've put something in the mail. We are having our mail forwarded, but I did want to flag that. There is still somewhat of a Canada Post service disruption. So if you are waiting for a tax receipt, please know that there likely will be a delay. We are very appreciative for all contributions, donations, so you can make it easily and securely online on the website, and you will immediately receive a tax receipt. So it is a lot easier, but you can also always call our offices. So thank you for all of your gifts. And for more information on the website, we are recording today's webinar. You will receive it since you have registered, but you can also go to the OC Replay webpage and you can view all of our previously recorded content to help you find out if you're getting enough of the recommended nutrients. Visit the website also. You can download the nutrient calculator to your smartphone. And also, we have our podcasts. Those are available on the website, or you can go to iTunes or YouTube Music. Lastly, if you have not already, please subscribe to the website. We're on social media, all different ways that you can connect with us and we can connect with you. Thank you again to our speakers, our partner, and to all of you for joining us today. Have a great day. Be well. Take care.